relative hyper or hypomobility.
Yeah.
There's nothing relative about this. All right? What do you mean by relative?
If one part of the spine is not moving as well, other parts might move more.
Yeah, but usually that occurs further up. So if I've got a problem lower down, it tends to destabilise further up. We're actually talking about a C5-6 problem because a context is tennis elbow. So what role would a craniovertebral joint problem play in the tennis elbow?
If they have limitations in their head movement, when they have to compensate by, like what Gene's saying?
No, it tends not to occur so much. You'll destabilise something else. Mostly the problems below cause problems above, not the other way around.
When you talk about the T-spine lab, yes, sir.
Much the same thing happens there. It's problems below affecting problems up. Yeah? So we said when the subluxation lower down gives you this tends to know stuff further up. It's broken. No, I mean, this is what we said yesterday. If she's got a problem further down, you have to compensate it. If you can't compensate it for it uniformly through the neck, then it's going to concentrate on areas where it really should be concentrating. So by not allowing these forces to escape and adapt the head, then you have to do that lower down and then it overcompensates and breaks down. So this becomes a contributor. It's not a causal factor, but it's a contributing factor.
So you're saying that the C5 dysfunction, C5, C6 dysfunction is a contributing factor to her craniovertebral?
Well, it may be. That's not what I'm saying, though. Go back to the context. The context is tennis elbow. She's coming in with a tennis elbow problem.
Yeah.
Everything's got to be aimed at that. You need a problem at C5-6, don't you?
Yes.
That's it. If there isn't anything wrong with C5-6, then you're not likely to get a tennis elbow from the neck. So you need a problem at C5-6. It doesn't matter what this is causing, does it? Doesn't matter what it's causing. Her problem's down there. I don't care if it's disrupting the craniovertebral joints for the moment. I'm looking for contributing factors down there. So I don't give a damn what it's doing to the craniovertebrals. I'm more interested in what the craniovertebrals are doing to that. So if this can't do what it's got to do to adapt the head and neck to bring the eyes into the right position, then that gets done elsewhere. And if the forces are concentrating down here, then this gets beaten up. All right? The thing you've got to understand here is all about context. She's not complaining of headaches. If she was complaining about headaches, I'd be worried about what's causing that problem, because that's what's giving her a headache. Yeah? She's getting tennis elbow, so I'm worried about what's causing that. I don't give a damn what that's causing at the moment. She's not complaining of that. Is that okay?
Mm-hmm. Context.
All the time it's context. So anyway, having said that, let's have a look at craniovertebrals because there is interesting stuff here. All right, watch. Right rotation, AA, and she doesn't like that. Left rotation, AA. Is that better?
Yeah.
There. So I'll stick my finger in it. Now what we got is this movement is more restricted than that movement. But that movement is painful.
When you do the AA movement, you're locking the head, right? When you're doing the rotation?
No, actually I'm not. What I'm
Oh.
doing is I'm getting the end feel from my hand here.
All right.
Remember this one?
That could affect C3 too.
It can do, but I checked C2-3 and it's fine.
Yeah.
So we'll come back to this. This has more range than that, but this is more painful than that. In fact, this really isn't painful at all. That one is. What does it suggest? Hypermobility. It's hypermobile because it's got more movement than that, and this one isn't hypomobile because this one is hypermobile, and I know that's hypermobile because it's painful. All right? If you've got pain and tenderness, you've got a problem. It's as simple as that. Now, we look at the craniovertebral joints, and that's okay, flexion, AO joint rather, and then we come to this one, and right side bend and extension is restricted, which suggests what?
Right.
Hypomobile, right anterior.
Okay, so a hypomobility of the right joint into extension. Now, what I don't know if this is joint or if it's muscular. I can't really do a glide here because the suboccipital muscles run in the plane of the joint. So what I can do is hold relax. So I'll get her at the end of range. Don't let me move you, and relax. Don't let me move you, and relax. And if this is muscle again, I should be able to regain that range and feel an improvement, and I've done. So this is hypermobile. Hmm?
You get decreased pain also. If it's muscular.
No, I won't worry about the pain so much. The pain's not a terribly good indication of what type of problem you're dealing with, just that there's a problem. All right? It's really the range I'm interested in rather than the pain. And that actually hasn't changed this pain here at all, has it? Well, it has?
Yeah.
Don't be a pain in the neck. Disagree with me.
So
I
would
really
that-
don't care
would
about
that hypermobility be driving the hypermobility below?
Yeah, I mean, something's causing the hypermobility. Hypermobility just don't happen. They occur because something is causing it. Could be reflex inhibition, causing instability. It could be a radiculopathy, causing the loss of control there as well. But it could be mechanical, so overstressing. Now, these two movements are really not... Okay, so what you can't do is go anterior, which means you can't rotate the AO joints to the left. Yeah. But the hypermobility is into right rotation. So probably these have nothing to do with each other as far as cause and effect are.
How does that rotate?
No, it's this movement. That movement
Yeah.
is more than that movement.
How does that
That's
rotate?
right rotation.
Yeah, I just said that already, initially.
Yeah, watch what I'm doing rather than what I'm saying. That movement
Yeah,
is more than that movement. What rotation is that?
that's left rotation.
Yeah. That movement is more than that movement.
Okay. I just thought initially it was the other way.
No. Okay? There's this test.
Yeah,
That was excessive,
okay.
which is right rotation.
Yeah.
And what we said was that this is a loss of anterior gliding, as you said, which is actually what goes with left rotation for the AO joint. So as a cause and effect thing, mechanically it's tough to argue that these have anything to do with each other.
So would you then just leave the OA alone at that point, or you manipulate?
Well, really what I need to know is, do I think the AO joint is playing a role in what's happening down there? So it depends on what I find at C5-6.
Would you consider vestibular stuff at that point? Because if there's vestibular issues, aren't there?
Well, did I find evidence of it when I was doing the scan?
I don't know, did you?
I don't know, it's not my patient. But you're asking me if I think that may be causing it? Question is, have I found any evidence of it?
Right, I'm just thinking because usually when there's vestibular issues, a lot of times there's cranio.
Yeah, but again, you've got to get this in context.
Right.
All right? The context is tennis elbow. Why would I have looked at the vestibular system for a tennis elbow problem?
As a contributory issue, again with the
How is it?
increased tone in the flexors causing
Those are
other
extensors.
compensations.
Yeah,
Those
how
are
will
extensors.
increased flexor tone cause a problem in the extensor tone? What it would do is decrease the extensor tone, not necessarily make it weak. Yeah?
Mhm.
So, I mean, you can argue that, but don't forget where I'm coming from. It's a tennis elbow.
Right.
So if I'm thinking this is a vestibular spinal issue, a cervico-vestibular issue, I will be looking for evidence of it through the body.
Right.
Not come up here and go, yeah, well, this is an AO joint problem, and the reason they may have that is because it's vestibular.
No, I'm just thinking it'll just start a
Don't
different path
stick,
of thought.
no, don't. We've got one problem at a time.
Okay.
You can't branch out with different questions and different problems with this stuff. You'll go all over the goddamn place and you won't know where the hell you are. All right? One thing at a time. If it's a straightforward question, can vestibular spinal issues cause hypertonus in the suboccipital? Of course they can. Yeah. Can it cause a dysfunction in there? I don't know. What you're going to do, if I have a problem on the right side, I'm going to increase the flexor tone here and the extensor tone in the leg. What's going to happen to the right rotation? Well, what I want to do is rotate the head away. So if I'm tipping that way, the tendency would be to do that, isn't it? So actually, it's probably not, because this thing's jammed back. But we're getting way out on a limb with this. Let's stick with the tennis elbow. So is that okay? I don't care about this, do I? Except as it affects the tennis elbow. Now, can it? Well, we've lost extension. So what I need is a condition that will cause extension. Right? What I'm, if I'm arguing this is compensatory from, say, a thoracic problem, yeah, then the only problem I'm really interested in, apart from segmental facilitation, is whether it's closing down on the foramen. So the question is C5-6 over-closing? If it is over-closing, why? Well, this is a perfectly reasonable thing, isn't it? This thing can't extend. So we've lost the ability to extend here, which will increase the need for extension down there. So it's not an unviable target by any means. Yeah.
But only if there was a corresponding
If,
thoracic.
well, no, only if I'm thinking this is a stenotic problem. Yeah. I really don't, again, the thorax would be a nice thing, but is this a stenotic problem? We can worry about, I mean, maybe a foot problem if we take this far enough. But is this a stenotic? If this isn't due, if that's not due to a stenosis, I don't give a damn about this. Well, not necessarily. I mean, the facilitation, if there is facilitation coming from here, maybe because this is overextended and dysfunctional, in which case, yeah, this becomes a target again. Yeah? But let's stick with the idea that this is stenosis. It's the easiest one at the moment. If this is stenosis, the evidence I should find of a stenosis is through the arm, isn't it? I should either find a radiculopathy, or I should find evidence of axoplasmic flow problems, one or the other, or both. If I'm not finding that through the arm, then I'm not too worried about this being a stenotic problem. In fact, I'm not worried about it at all. Yeah? If I'm not finding evidence of facilitation from there, then I'm not worried about the neck at all. So I found no stenosis or consequences of stenosis, and I found no facilitation. The neck now becomes a non-target. Move away from it.
Would you
Even
also-
though I've got problems up here.
Would you have, would you need neck symptoms
No.
to be stenotic?
No.
Like the stiffness and all that stuff?
No. We're looking at very small degrees of stenosis here.
So even small degrees of stenosis will give you the
Certainly affect the
radiculopathy.
axoplasmic flow,
Right.
but we're looking at a single level stenosis. Yeah, it's lateral stenosis. There may be no symptoms at all, and don't forget, in the arm, often even with severe stenosis, pain's not your main indicator. It's neurological stuff. So this comes on gradually.
How does axoplasmic flow affect it locally? Let's say it is a C5-6 issue. How does that C5-6 issue affect the cervical spine in terms of flow? Is there any effect at all?
No, it's the other way around. How does the cervical spine affect axoplasmic flow?
Right, that's what I mean. But if it's just an issue at C5-6,
Yeah.
is there effect of flow going superior, or is it just going down?
Now, we're only interested, really, as far as I know, until somebody does a bit more research on this, we're only interested in antegrade flow, not retrograde flow. Now, it's quite possible retrograde flow, if you have a build-up of metabolites, that this could be damaging. I honestly don't know, and I don't know if there's been any study on this. But what we are doing is talking about stuff we do know about, we think, which is really the antegrade flow. So the only flow direction I'm really interested in is peripheral. Yeah? So that's what I'm looking for. I'm looking for evidence of basically segmental paresis of whatever kind. If I'm picking up evidence that it's axoplasmic, that is rapidly fatigue and weakness and no other neurological signs, and it's segmental in nature, so it's not just the wrist extensors, but also maybe the elbow flexors, then I'm thinking this is coming as a part of a radiculopathy. If on the other hand it's just the wrist extensors, I'm thinking, well, maybe this is double crush. And she's got a bit of a problem in the neck, which I suppose we could term radiculopathy, and maybe a second crush down elsewhere.
So I guess a question like that, and this would be pure theory, is if you're talking about axoplasmic flow going peripherally, and if there's an issue at OA, right, that's the first level where that axoplasmic flow will go. So if there's an issue that's...
No. You're talking about spinal cord problems now,
Okay.
aren't you? I'm not, again, you're going to get axoplasmic flow through the rami
Of each
of
level.
each segment.
Okay.
But if this is an axoplasmic flow problem from the AO joint, it's going to be affecting the muscles in the tissues in the head.
And it wouldn't just go distally.
No, it won't, because that's now you're looking at spinal cord.
Gotcha.
Is that okay? So are you okay with it? So the question is this a viable target? Only if the neck's involved. Only if I think this is either a stenotic problem and that matches it nicely. Or I think this is segmental facilitation, and this is jamming into extension. Does this now become a viable target? Yeah? All right, was there anything else there?